dear doctors, welcome to 𝗲𝗵𝗵𝗺. That's a beautiful play school where we discuss about the children. So, pediatrics classes started by me, myself Dr. 𝗲𝗵𝗵𝗺, under the heading of 𝗲𝗵𝗵𝗺 is under the neonatology domain. We are discussing about the neonatology, and in neonatology this lecture is going to be on neonatal respiratory distress syndrome. Now, neonatal respiratory distress, I have already told you about the approach to neonatal respiratory distress, where we have discussed very important things like the Silverman-Anderson score, like the Downs scoring, alright, and every other thing about that. What is the classification also we have discussed, okay. Now we'll discuss about the neonatal respiratory distress syndrome. Now, neonatal respiratory distress, this is our 7th lecture. This is also called as Hyaline Membrane Disease. So, neonatal respiratory distress is also called as Hyaline Membrane Disease, or it is also called as Surfactant Deficiency Disorder. Surfactant Deficiency Disorder. So, this is actually a very important, I think the most common cause of respiratory failure in premature infants. Understand this very carefully, my dear friends. I am not telling you that it is most common in preterm. No. In fact, the most common in preterm is not respiratory distress, but it is not respiratory distress, but what it is the transient tachypnea of newborn, which we are going to discuss in the next video. But one thing which you have to understand is that we are discussing about the we are discussing about the respiratory distress, which is most common in premature infants. Now, what is premature? So, what is the difference between premature and preterm? So, the difference is that the premature has got less or no lung maturity. So, if the lung is not matured, this is called as premature baby, and preterm means less than 40 weeks. Less than 40 weeks. So, what is the cause? I have told you it is also called as surfactant deficiency disorder. So, there is insufficient surfactant level which is there, and of course, because the surfactant level, okay, what is the function of surfactant? So, surfactant, this is a very important MCQ which I am going to discuss right now. That surfactant is composed of lecithin. Surfactant is composed of lecithin, alright, phosphatidylcholine, if I just enter in the core biochemistry. So, this is responsible for decreasing the surface tension. It is responsible for reducing the surface tension to oppose. Now, what it is going to happen? Because there is a less surface tension, it is going to oppose the collapsing pressure during expiration. So, for example, this is your alveoli and there is a lot of air inside. So, whenever you are going to do expiration, the air is going to go out, and of course, the alveoli will try to collapse. So, who is the one who is going to prevent the collapse? Surfactant. Okay. Now, coming to important thing, that the mature levels of surfactant are reached by 35 weeks of gestation. Okay. So, if the baby has crossed 35 weeks, that means, of course, the baby has reached to a maturity. So, a premature child means the lungs are not mature, and premature means 35, less than 35. So, remember 35, 5 is called as penta, P for penta, P for premature. So, 35, less than 35 weeks, we consider it as the premature baby. So, what happens? There will be lack of ventilation because now there is no surfactant. The alveoli is going to come together and close, which is actually called as progressive atelectasis, okay, the closure of the alveoli. So, what is going to happen? There will be loss of ventilation that results in hypoxia, decreased oxygen, more carbon dioxide, hypercapnia, acidosis, of course, because there is increased amount of carbon dioxide. So, the pH, the H positive ions is going to increase, and of course, the pH is going to drop down. What it is going to cause? It is causing the pulmonary artery vasoconstriction. So, understand this beta, whenever there is increase in amount of CO2, that leads to muscle contraction. Which muscle contraction? Smooth muscle contraction. And of course, if the smooth muscles of vessels, smooth muscle contraction of vessels, If the smooth muscles are going to contract, this leads to what? This leads to vasoconstriction. Alright, this leads to what? That leads to vasoconstriction. So what is going to happen? The pulmonary artery is, okay, I'll again draw this diagram for you. For example, if I just draw this, yes. So, okay, if I draw like this is going to be of two parts. This is the pulmonary artery which is going to be there, and because there is less oxygen, this pulmonary artery is going to show vasoconstriction, and because there is vasoconstriction, that means a lot of blood is going to come here. This is your aorta which is going out, and there is a connection between the pulmonary artery and the aorta. This is called as ductus arteriosus. Of course, not in adults but in newborns, ductus arteriosus. So what is going to happen? The blood in excess is going to travel to the aorta. Alright, it's going to travel to the aorta. So from the right side, it is traveling to the left side. So because of pulmonary artery vasoconstriction, there is right to left shunting through the lungs, through the foramen ovale and ductus arteriosus. Yes, of course, ductus arteriosus I have told you. Okay, the other thing is the foramen ovale. So where is the foramen ovale? Yeah, can you understand? Here will be the foramen ovale between the the septum primum, septum secundum and everything from embryology, foramen ovale. So what is going to happen? There will be decreased perfusion. Of course, the alveoli is not receiving, so there will be decreased perfusion. That means perfusion means less blood is coming from alveoli to blood. Less blood is coming from alveoli to blood. There is, less oxygen is coming from alveoli to blood. That leads to what? That leads to decreased perfusion, which causes ischemic injury to the lungs. Of course, the lungs will be having injury. Alright, and once it is injury, okay, I think you know that lungs have got pneumocytes, and these pneumocytes are responsible for production of surfactant, right? Now, if there will be lung damage, there will be no pneumocytes, there will be decreased surfactant. Of course, this decreased surfactant further causes a proteinaceous effusion, alright, that is going to enter into the alveolar space, and of course, it leads to more lung injury, and the respiratory is going to come in distress. The respiration is going to come in distress, respiratory distress syndrome. So, main risk factors I have already discussed, right? The insufficient surfactant levels, one cause. The other cause is the male sex, right? Maternal diabetes. Maternal diabetes is also a cause for neonatal respiratory distress. Why? This has been covered in the previous video. So now it's your turn to tell me in the comment section that why maternal diabetes is responsible for causing neonatal respiratory distress. Okay. Next is multiple birth. Alright. And cesarean section without a trial of labor. Now, please understand, my dear friends, what is going to happen during labor. If the female goes in labor, labor is a very stressful condition. So, in this stressful condition of labor, there will be a release of cortisol, and this cortisol stimulates the release of surfactant. Very simple. Okay, cortisol releases the surfactant. Okay, so very simple. So, there is labor, cortisol that leads to surfactant. Now, if there are multiple births, that means birth canal is open. Birth canal not open, but birth canal is wide because the multiple births have taken place. So that causes a rapid labor. A rapid labor means there is decrease in amount of cortisol, decrease in amount of surfactant. Similarly, if you perform a cesarean section, okay, some females are, oh doctor, I can't take the labor pain, please do a cesarean section. And if you go for the cesarean section directly without even a trial of labor, what is going to happen? There will be no surfactant released, and of course the baby can go to respiratory distress. And if there was an intrauterine asphyxia, this is also a predisposing factor for a neonatal respiratory distress syndrome. Alright, coming on to what are the signs and symptoms. I have told you, shallow respiration and fast respiration. There will be just like this. Okay, this is a fast and shallow respiration. Grunting is there, flaring, cyanosis, intercostal retractions, everything I have told you in the previous video, so you can visit it once. But now very, very important part, Neonatal Respiratory Distress Syndrome. That's really, really, really important. Okay. So what is going to be there? So remember, first of all, take the ABG. What you will see in ABG, there will be pH raised. Sorry, pH will be decreased. Carbon dioxide increase. Oxygen decrease. First thing. Next is going to be chest X-ray. Alright, chest X-ray. What is going to be shown in the chest X-ray? In respiratory distress syndrome? Yes. This is the chest X-ray of a respiratory distress syndrome patient. This is the chest X-ray in the respiratory distress syndrome patient. Okay. So can you see that there are multiple opacities, very white lung, and very less blackening, because there's low air which is there, and mostly what you're going to see is just the white things, because the alveoli are collapsed. Okay, so white things are going to be there, no air, no blackening, that will be seen. And you will check the lecithin-to-sphingomyelin ratio, that's more than 2:1 in amniotic fluid. Alright, if it is more than 2:1, then that means okay, less than is good. But if it is less than 2:1, of course, we can see that it is not good. Okay, how to check? It is actually checked in the amniotic fluid. Okay, so if you see in the amniotic fluid, lecithin-to-sphingomyelin ratio is more than 2:1, fine. But if it is less, please start the mother with the glucocorticoids, because I have told you that more the amount of glucocorticoids, or glucocorticoids are also called as steroids, not steroids actually, yeah, steroids, or you can say cortisol. So if there is increased amount of glucocorticoids, increased cortisol, it leads to increased amount of surfactant. So in order to increase the amount of surfactant, what we do, we give the glucocorticoids to the mother. Alright, of course, we have to give the oxygen also, right? And one more thing which we have to do is check the X-ray, which will show the ground granularity. Okay, ground glass granularity I've already shown you. What are the complications of neonatal respiratory distress? Of course, there will be a persistent patent ductus arteriosus. Ductus arteriosus, the connection between a vasoconstricted aorta and vasoconstricted pulmonary artery and aorta. There was a connection which actually obliterates after the baby is born, but because there is a lot of blood in the pulmonary artery, this has to go to the aorta. So there is a persistent patent ductus arteriosus which is going to be there. Alright. Other complications which can be there is going to be retinopathy of prematurity and bronchopulmonary dysplasia. Bronchopulmonary dysplasia means now that there will be no new cells formation. Okay, no parenchyma formation. Okay, or you can say that improper parenchyma of the lung will be start to get formed. And what about retinopathy of prematurity? Of course, because of decreased oxygen, there will be free radical formation which is going to be there, and this free radical formation is going to damage the eye. Okay, in fact, free radicals are also formed if there is lot of oxygen, but yeah, in decreased oxygen also this can happen. Alright, and yeah, there will be, now let's understand why there is leading to, why there is retinopathy of prematurity. So what happens is, there is decrease in oxygen, and because there is decrease in oxygen, it leads to what? It leads to VEGF. What is VEGF? Vascular endothelial growth factor. So there will be a release of vascular endothelial growth factor, which will cause the vessels to proliferate. So vessels are going to proliferate, and this abnormal proliferation of vessels leads to what? Leads to retinopathy. Leads to what? Leads to retinopathy. So this is what you have to remember. So hypoxia leads to VEGF, leads to abnormal proliferation of the blood vessels, and actually this abnormal proliferation is something which is called as retinopathy of prematurity. Alright. So yeah, this is it. Coming on to treatment. So remember, of course, because it's a respiratory distress, you have to give what? You have to give the steroids. Okay. And glucocorticoids, if you can give in the antenatal to the mother, of course, it's good prophylactically if it is given. Okay, what else you can give? Of course, you can start with the steroids. You have to give oxygen. Alright, everything you have to start. So see here, corticosteroids, then surfactant. Yeah, of course, you can start with the surfactant also, if the surfactant is very low. Now, this is a dictum that prenatal corticosteroids are the mainstay for prevention for all women expected to deliver at less than 34 weeks. You have to give the steroids, alright, if the delivery is expected to occur at less than 34 weeks, alright. And then neonatal resuscitation is really important, okay. And empirically, we are also giving antibiotics like ampicillin and gentamicin. So empirically, we give the antibiotic ampicillin, we give the antibiotic gentamicin. Why we are giving it? Because distress can be worsened by the bacterial infection, so we don't want the worsening. So we prophylactically we are giving the ampicillin and gentamicin. And in order to give artificial respiration, okay, in order to give, sometimes baby is not even respiring. The baby, even if you give the oxygen, alright, oxygen from outside, but there is no breathing which is going to occur. Okay, there is no breathing which occurs in the baby. You give oxygen, baby is not taking inside, so then you have to give the artificial respiration with the help of continuous positive airway pressure. That means you are positively inserting the oxygen inside the lungs. Or what you can do, you can intubate the patient. Okay, just give a cut in the echothyroid membrane, insert the tube and intubate. Alright, and this is the mechanical ventilation which is there. So this marks the end of this video. I hope this video is useful to you and things have been registered in your brains. Thank you so much.